again, thank you so much for joining us today. I think this is a fascinating topic personally. The topic for today's webinar is Treating Eating Disorders with Psychedelics, a Guide for Parents. We were supposed to have two presenters, Dr. Amelia and Dr. Wassenaar. However, Dr. Amelia is not feeling well, so Dr. Wassenaar will be doing the webinar on her own. And I just want to go through a few very quick house rules. Basically, we're going to ask you to please keep your camera and your microphone off during the duration of the webinar. If you have a question, please put it in the chat box and we'll get to it at the end of the webinar. I'm going to ask that you only put questions in the chat box. Please don't put side chats in the chat box because it's really hard for me when I moderate the questions to find them amongst all the various chats. So that's A. And B, I'm going to ask you for another favor, which is Dr. Wassenaar can't answer personal questions about your particular child or loved one. So please keep your questions pretty basic and pretty open and not a specific case, because I don't want to put her in a position where she can't actually give you a concrete answer. So now I'm going to turn it over to Dr. Wassenaar. Thank you so much for joining us today.
Thank you so much. Let me go ahead and get my screen shared. And while I do that, I will introduce myself. My name is Elizabeth Wassenaar. I'm a child and adolescent psychiatrist, and I practice at Eating Recovery Center in Denver, Colorado. I also am a researcher, and I do research on the use of ketamine in eating disorders. So I'm going to talk to you today about an exciting and emerging field regarding psychedelics and how they may have a place potentially in the future of eating disorder treatment. First, want to say that I have no disclosed financial relationships in any amount in the last 24 months per this statement. Okay, so we're going to start just with some definitions. And so first off, what is a psychedelic? What's a psychedelic substance? Psychedelic is a, let me see if I can make, sorry, this, a psychoactive substance that can induce a perceptual disturbance, cognitive distortion, and emotional and mood alterations. We're also going to talk through the legalities of these substances in the United States, which includes, oh my goodness, is there a way to make, sorry, Judy, all the people in the waiting room keep coming up on my screen and it's hard for me to read my slides. Is there a way to make that stop happening?
In theory, I can stop making you a co-host for now.
Okay, that might work.
If I knew how. Allie, would you help?
Yes, one second.
Thank you so much. I'm so sorry. Okay. All right, we'll see if that works better. Okay, so we're going to talk through the legality of these substances in the United States. I will say that my knowledge of the use of these substances globally is very limited. So I will be, I have very, very limited ability to speak to the global use of these substances. In the United States, there is a way that we organize medications and substances and drugs called the schedule system that's put out by the Drug Enforcement Agency. So Schedule 1 substance is a substance that's classified by the DEA as having no medical use, is dangerous, or with high abuse potential. At this time, the majority of the psychedelics are classified as Schedule 1 substances. And then Schedule 2, 3, and 4 substances are substances that can be prescribed and have variable risk levels. And the one substance we're going to talk about that's a Schedule 3 substance is ketamine. So ketamine is a substance that is prescribable currently. And then we're going to talk about the idea was called breakthrough status. Breakthrough status is actually a status that's classified by the Federal Drug Administration, the FDA, and is intended to expedite development and review of drugs for life-threatening conditions. And we're going to talk about some of the emerging research and some of the substances that have been classified with breakthrough status. Okay, so let's just start big picture. So psychedelics. So we've said that these psychedelics are substances that induce are psychoactive substances that induce sort of perceptual changes, etc. And also, the field has become very murky in terms of what exactly these are. So I wanted to put out to you sort of the big names that you may hear that are considered to be psychedelics. So the classic psychedelics, these are the substances that have been sort of studied in the field for the last 80 years or so. Include substances like LSD, psilocybin, ayahuasca, which is actually a substance with DMT in it, and then mescaline. The neoclassic or non-classic psychedelics include 5-MeO-DMT, ibogaine, MDMA, ketamine, and salvia. And as you'll notice as well, there's sort of two substances, the tryptamines and the phenylethylamines. Those two substances tend to have, and we'll talk a little bit on the next slide, a little bit more of a classic perceptual change experience in terms of a psychedelic experience, whereas the dissociative anesthetics like ketamine and salvia are classified as dissociative and tend to induce more of a dissociated experience. And then I put over to the side the tetrahydrocannabinoids or marijuana, because marijuana is not actually a psychedelic. It is not in this sort of sphere, but it does induce perceptual changes, mood alterations, and some people are studying the use of marijuana in the treatment of mood and anxiety disorders. We are not actually going to talk any more about marijuana in the treatment of eating disorders today, because the use of marijuana in eating disorders is not promising. We've not really seen it to be effective. So, but I did want to put it on this slide to say it is a Schedule I substance in some places. In some places it's legalized, and it's going to be reclassified soon, but that does cause perceptual differences. Okay, so this is pulled from a 2019 paper looking at the subjective experience of people who took psychedelics in either a medically monitored setting or as a self-report, and were presumably used in illegal settings. So this is more just to talk about the fact that just because psychedelics is a sort of big umbrella term, actually each psychedelic substance does have a bit of a different impact. And as we get into more of the research of what's happening in the psychedelic field, some of the ways that the psychedelics work differently is actually informing how we are using these substances to treat different kinds of mental illnesses. And this could actually be important when we think about using psychedelics in the treatment of eating disorders in the future as well. I think the thing that is important to sort of recognize where there is a big separation out. So ketamine is obviously the single psychedelic at this moment that is legal for prescription and available for people to access. Ketamine as a dissociative anesthetic has the highest experience of disembodiment, or feeling like one is outside of their body, and less of a other perceptual changes experience. And then if you'll go down the table a little bit, you'll notice MDMA, which again is a non-classical psychedelic and doesn't have hardly any experience for people on a perceptual change, but is described to be highly blissful and is believed to work more in the system that interacts with relational connection and oxytocin and things like that. So MDMA has a unique role in the treatment of especially PTSD and relational disruption. So psychedelics are probably actually one of the oldest pharmacologic agents that humans and humanoids have used. There's evidence in the archaeology literature of the use of psychedelics back centuries and generations. But in modern day, psychedelics were sort of rediscovered or discovered in the scientific laboratories of the 1930s and 1940s. And it wasn't really realized what they were at the very beginning, but then people began to sort of experiment with them, as they did in those days with new drugs, and discovered that they induced perceptual changes and potentially had a role in the treatment of mental illness. And so you'll see this is actually just psilocybin, but the other psychedelic agents actually mirror this sort of graph. There was an explosion of research and a lot of interest in the use of these substances from the 1950s to the 1970s. And they also made their way into the popular culture, into popular use. And the way that they made their way into popular culture, along with some other movements of the late 60s and early 70s related to the oversight of psychiatric substances and prescription substances, led to the Controlled Substance Act of 1970. And that's when the schedules were introduced. So that's when these substances actually became illegal. And when they became illegal, they became very, very difficult to do scientific research on it. So you can see that the overall number of publications and studies fell precipitously through the 80s and 90s. And then in the early 2000s, we started to, we didn't have new psychiatric drugs. We are sort of needing to do something about mental illness and look at the field. And so we started to see an increase in the psychiatric research of psychedelics. And ketamine was really the first thing that broke through those barriers in the late 90s. So, but just a reminder that ketamine has actually always been legal. Ketamine is a Schedule III substance. It has always been able to be prescribed by physicians, and it has been safely used for decades as a rapidly acting anesthetic that preserves the airway. It wasn't until the mid-late 90s that we realized that a lower dose of ketamine could be helpful for the treatment of depression. And we're going to talk more about that in a little bit. Oh, right here. Okay, in the 1990s, sub-anesthetic ketamine was noted to be helpful in a single dose as a rapidly acting antidepressant agent for treatment-resistant depression, which was a groundbreaking and very exciting. And within the decade that followed, those studies were able to be repeated and saw that they were still actually helpful. And the one thing about ketamine is it acts fast, but then it comes off fast. So people feel better quickly. They can get out of acute psychiatric crisis, acute suicidal crisis, but then that is not persistent. So a lot of the work we've done in the last 2 decades on ketamine has been how to help the experience be more persistent. Nevertheless, S-ketamine, or Spravato, was approved for treatment-resistant depression in 2019, and no doubt, no matter where you are in the world, there's a ketamine clinic that is not too far away from you. They are just about everywhere these days, and I think that that's probably a separate lecture about how easy it is to access ketamine and also whether or not it's helpful to just use as a single agent. MDMA and PTSD. So MDMA began to be studied for PTSD through the 80s and into the 90s. And it was just this year, maybe the beginning of this year, end of last year, that the scientific corporation that sort of has been studying MDMA put in a new drug application for a analog of MDMA. And I heard, I'm at APA this week, the American Psychiatric Association, and I heard that they are expecting to hear about the new drug application on August 11th of this year. So that is exciting. And we will see what comes from that new drug application. Psilocybin is currently being studied in a lot of things: mood disorders, eating disorders, and trauma. So this is where that breakthrough status comes in. So the FDA has classified both psilocybin and LSD to be breakthrough treatments, which means that they are uniquely effective for the treatment of difficult diseases and deserve to be sort of pushed through the process a little bit faster. Psilocybin was given that status about a month and a half ago for a psilocybin analog, along with psychotherapeutic support, and LSD and generalized anxiety disorder was given that status on March 26th with, again, an analog of LSD. The interesting thing about the LSD trials is that LSD was given to patients with anxiety disorders without psychotherapeutic support. So I haven't seen those studies. Generally, when they're in breakthrough status, the studies are in the sort of black box, and the FDA has them. So I'm very interested to see what sort of research they're seeing, what sort of outcomes they're seeing. But we're here today to talk really about eating disorders. And so what do the psychedelics, what do we know about psychedelics and eating disorders? So there's a couple small studies looking at psilocybin and anorexia nervosa, and have shown that psilocybin can be administered safely in patients with anorexia nervosa. In this small study that looked at the administration of psilocybin for people with anorexia nervosa, those patients were stable enough to be at an outpatient level of care. So they were in a specific state of their disease where they were able to maintain their nutritional status and be in an outpatient level of care. And there is an ongoing study at UCSD called COMP360 that is recruiting for patients with anorexia nervosa, adult patients, 18 and up, to have psychotherapeutically supported psilocybin administration for the treatment of their eating disorder. MDMA and eating disorders, anorexia nervosa, bulimia nervosa, and binge eating disorder. So there is a small open label trial that looked at MDMA-assisted psychotherapy in patients with PTSD and eating disorders, and was found to be that they had significant improvement in their PTSD symptoms as compared to placebo. And so there is a trial that the MAPS Corporation put together for looking at the use of MDMA and directly targeting the symptoms of the eating disorder. At this time, they are not recruiting for that study as they have decided to focus most of their efforts on getting the new drug application for MDMA approved. And then ketamine and eating disorder diagnoses. There are multiple trials going on around the country looking at ketamine and eating disorders and various other interventions. And case reports have shown generally good response to ketamine for the treatment of patients who have something and an eating disorder, typically treatment-resistant depression, but sometimes significant suicidality and an eating disorder diagnosis. So this is looking at the case studies that exist. The thing about these particular ketamine studies is that all of these patients were at an outpatient level of care. So they were able to be stable enough at a lower level of care and maintain their nutritional status at a lower level of care. These are just some of the articles, and I like to sort of be able to share these so that beyond the scope of this topic, if these are things that you're interested in or you want to talk with your providers about, you can help them to find the literature. So this is a good review of what is out there. This is a look at all those trials and the review of the current evidence. And then this is actually a write-up of the that UCSD study that is just sort of like how the study would be arranged. Oh, and this is the MDMA study. So overall, there is some data that shows potential future for psychedelics and eating disorders in a review article that, again, interviewed adult patients with eating disorders and who had used psychedelics on their own, again, either internationally or in sort of underground, which is what the language people use to use these substances illegally. 28 patients with a lifetime eating disorder diagnosis reported significant improvements in depression and well-being after taking a classical psychedelic. I think that while these data are hopeful and promising, the important thing to remember is that right now, most of the data we have is patients who are sort of coming forward and talking about their experiences because it worked for them. They've had a good experience, or they had an outcome that they want to share. What we're not hearing about is all the people that tried and it didn't work, or it made things worse. We're really not seeing those patients. So I want to be careful that as we review what exists in the literature, it is a selection bias amount of data. So we do not have sort of a rigorous placebo-controlled, divided group of people who might be able to give us more objective experiential data for how psychedelics might be used in the treatment of an eating disorder. And then I threw ayahuasca on here just as last sort of footnote, because with ayahuasca, which is a brewed psychedelic tea that is generally available in Central America, Central and South America. There's only a few case reports. I think that, especially thinking about the fact that a substance like ayahuasca requires some level of potentially international travel, thinking about the level of stability a patient would need to have to be able to access something like that is an important consideration. Okay, here's these, these trials. Okay, so eating disorders, obviously, we know that the impact of malnutrition and starvation on eating disorders can be very profound. We have few medications for the treatment of eating disorders, and nutrition is the most important intervention. What we have that is legal and prescribable right now is really two medications. We have fluoxetine, which is available for the treatment of bulimia nervosa, and Vyvanse, which is for the treatment of binge eating disorder. There are no other medications that have an FDA indication for the treatment of an eating disorder. And in fact, there are some prescription medications that may actually make things worse. Nevertheless, in the field of eating disorders, and you all may have experience with this as well, you'll know that we very often use medications to treat the comorbidities associated with the eating disorder, especially distress or cognitive distortions related to nutrition and food thoughts. So the bottom line is we don't have enough for the treatment of eating disorders, and especially not severe or treatment-resistant eating disorders or severe or treatment-resistant mood disorders that can co-occur with eating disorders. We know that the longer people are sick, the harder it can be to get them well again. And we are certainly at a precipice, as I sort of was able to experience this week at the APA conference, of an improved understanding of the neurobiology of psychiatric illness and improved neurointerventional options for the treatment of psychiatric illness. And I, as mentioned, Dr. Amelia was unable to be here, so some of these are her slides. So I'm going to go through a little bit of this a little bit quicker. To say we have a lot of patients getting intensive treatments as psychotherapies, nutritional therapies, nutritional stabilization, and psychopharmacologic support that are not yet getting better. There's a pressing need to identify alternative treatments and options for care. And part of why this is so important is that some of you may be aware that there has been a discussion in the field regarding the idea that anorexia could potentially be terminal, or could potentially have a phase at which treatment is no longer helpful. And there's been articles in the press, in the literature, put forth by an eating disorder physician, Dr. Jennifer Gaudiani, and an eating disorder psychiatrist, Dr. Joel Yeager, to discuss the idea of something called terminal anorexia. I think it's an important thing to note that Dr. Gaudiani spoke at the International Conference on Eating Disorders this year, and retracted the term terminal anorexia. However, as I have been, I'm in New York right now talking with the international psychiatrists, and the idea that eating disorders may have a terminal phase is something that has now been entered into the press. And so I think that it's important that we in the field push back on the idea that eating disorders have a terminal phase. Part of the definition of a terminal disease is that no treatment exists. And we know that for eating disorders, the treatment does exist, and it's nutrition. And also the treatment can be very, 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 very difficult. It is the sort of the core tenet of the disease, that the treatment necessary is the hardest thing to accept, which I think nevertheless leads us to this conversation of what else might be on the horizon to support patients who have a severe course of their eating disorder. So in our system, when someone has, sorry, I have a thing that's on my slide. It's making it hard to read my slides again. When someone has a severe course of their eating disorder and they've tried a lot of sort of typical treatments, we have a process by which we do a completely brand new ground up neuropsychiatric consultation. And generally, that includes both a psychiatric assessment and a medical assessment, as well as a review of any psychological testing done, or if neuropsychological testing would be recommended, then that would be something that we would potentially facilitate in the course of the neuropsychiatric workup, a review of history, review of treatment, and then thinking about what are the options that have been tried or have not been tried. So as we talk about what might be on the horizon for substances that are not yet available legally, it is important to note that there are several substances, that there are several interventions that are available as of today. So ketamine, as we've talked about, which has a unique ability to act as a fast-acting antidepressant agent, and as a agent that can specifically target suicidality, which we know can be a really difficult symptom when patients are faced with the idea that they need to get that nutrition in. They can feel very overwhelmed and very desperate. And sometimes their suicidality impacts their ability to safely remain in eating disorder treatment. So ketamine is an option that we use at Eating Recovery Center after a full and comprehensive evaluation. Transcranial magnetic stimulation, or TMS, is a non-invasive procedure that is actually a magnet that sort of sits on top of the head. And there's a special procedure that helps that magnet to get to exactly the right place in the brain, and helps to change some of the electrical potentials around the parts of the brain that can be kind of stuck on some of those thoughts. And then some of the other things that exist now are electroconvulsive therapy, which can be very effective for depression and anxiety, depression, especially severe depression, vagal nerve stimulation, which can also be very effective for depression, trauma, and actually somatic experiences of fullness. And then deep brain stimulation, which is obviously an invasive neurosurgical procedure where a stimulating device is implanted in the brain, but has been shown to show effectiveness for severe treatment-resistant OCD. And there are trials underway looking at the use of DBS for anorexia nervosa. So when we think about sort of the way the field has evolved, it used to be that we thought about using all of these interventions, TMS, DBS, ketamine, and the emerging psychedelics, to think about treating the comorbidities of the eating disorder. And even still, right now at Eating Recovery Center, we use ketamine primarily for the treatment of treatment-resistant depression or treatment-resistant suicidality. However, I think that as the field continues to evolve and the research continues to evolve, we may be able to gather information about the use of novel interventions and psychedelics for the treatment of the core symptoms of the eating disorder. Specifically, the identity fusion with the eating disorder, some of the cognitive rigidity that can result from the eating disorder, and some of the ways that the brain can sometimes get a little bit stuck on those eating disorder thoughts, or stuck on body image distress, et cetera, the things that keep people from being able to get the nutrition that their body needs. This is a fantastic article that I think is available for free if you just Google it, that Dr. Amelia was actually quoted in, looking at just a big picture of where the field's at on the future of eating disorder treatment, and talking again about what's available now and what might be available in the future. We know that a lot of patients with eating disorders have difficulty to treat depression, and that the comorbidities associated with eating disorders can make response to treatment very, very difficult. This is a history looking sort of at some of the history of ketamine, actually, and the fact that, let me see if there's anything on here we haven't covered. I don't think so. Anyway, it's come a long way. and that it is available by prescription now as S-ketamine or Spravato for the indication of treatment-resistant depression. And a lot of organizations and ketamine clinics are actually using generic ketamine, which is a racemic mixture of S-ketamine and R-ketamine for the off-label treatment of treatment-resistant depression and suicidality. And at ERC, we actually also use off-label generic ketamine for the treatment of treatment-resistant depression, as I've mentioned. Okay. This just talks about some of the ways that we theorize that ketamine probably works. I think that the big take home from this particular slide is that one of the promises of ketamine that is one of the reasons that I personally study it and evaluate patients for the use of ketamine in the course of their treatment is ketamine has a unique ability to stimulate a neurotrophic factor called BDNF, or brain-derived neurotrophic factor, which is a factor in the brain that causes new neuronal growth. So one of the things that we always thought about the brain, this is taking it back maybe a couple of decades, is that once you got out of adolescence, your brain was just done. Like your brain was your brain, and it was static, and it was, sort of like cast in stone. But what we have learned, and partially through some of this research that's gone on in the past couple of decades, is actually the brain has an incredible ability to continue modifying itself, even into adulthood, which is very, very promising for the treatment of eating disorders, especially those eating disorders that start in adolescence and persist into adulthood. But actually, it's very promising for a lot of mental illness to say that we actually always have the opportunity to change our brain. However, as we get older, changing our brain, growing new neurons is hard. But something like BDNF, which can be stimulated by the use of ketamine, can actually fertilize the brain to be more malleable or more able to grow new neurons or change neuronal connections, which is very, very hopeful and promising for the future of the treatment of things like eating disorders. The way that we believe that ketamine works is at a number of levels, and this is likely also generalizable to some of the other psychedelics, but we do not have that data yet. So this is just what we do know about ketamine, is that ketamine works on a biological level by resetting emotional reward connections and centers, buffering fear, and reducing cognitive inflexibility. And the NMDA receptors, which are a way that the ketamine works in the brain, are one of the ways that we believe that they actually modify fear conditioning behaviorally, because they increase neuroplasticity for a couple of weeks following just a single dose of ketamine. And if we engage in very intentional behavioral therapy after giving someone a treatment of ketamine, we can actually help them to form new habits easier. And then experientially, ketamine as a dissociative anesthetic does induce a non-ordinary state of consciousness. So it is mind-opening and expanding, heart-opening, and may reduce the avoidance of painful memories, and then can also induce the connection with mystical experiences. And as with all things, ketamine is important to be, it's important to be careful with ketamine. Ketamine has been misused. It has fortunately remained available for prescription, which is, I think, helped us to know more about ketamine than the other psychedelics so far. But ketamine can be misused, especially in party situations. It was a club drug, especially in the 90s. And so it's something that if ever I'm evaluating someone for the use of ketamine in the course of their treatment, I'm very careful to evaluate their history of substance use and misuse. And I also, carefully consider the prescription of these medications in younger patients and the risk of exposing them to something like ketamine when they're in a vulnerable state of adolescence. However, at this point, we are seeing mostly positive benefits of the use of ketamine, and overall ketamine is well tolerated with minimal misuse. Although as it becomes more and more available, especially in non-medically monitored situations. We are starting to see some cases emerge of people misusing ketamine or using their ketamine in ways that are not meant to be. So the FDA in America has actually issued a warning that ketamine should be used only in medically monitored situations. So in a clinic or in collaboration with your prescriber or therapist, so that it is something that's carefully monitored and supported. We are also seeing that for patients who take higher doses of ketamine over a longer period of time, they can have the risk of something called cystitis, which is like an irritation in the feeling that you have to go to the bathroom. So it irritates your bladder, and you can get a feeling like you have a urinary tract infection when in fact you do not, and it's induced by the ketamine. That actually goes away once the ketamine is stopped. We talked about this. Ketamine works fast, but not long. So oftentimes requires repeated dosing and requires that it be titrated to effect. In terms of how long people need to be on ketamine before it is can be persistent, that is something that we just don't know. We don't have that data for how long people are needing to be on the ketamine psychotherapy. Generally, in our practices, I prescribe ketamine for a discrete period of time and then take a break and see where the symptoms are at, especially in light of some of the emerging data around the ketamine cystitis. At ERC, when we induce ketamine, when we evaluate people for ketamine, we do careful medical screening, and especially in the patient population that has malnutrition, we watch very carefully for uncontrolled medical symptoms that could increase the risk to an unsafe level. And we support patients usually at a higher level of care to be getting their nutrition consistently so that we can make sure that they will have a good cardiovascular support system for this process. For ketamine, we want to be careful about a history of mania or schizophrenia or psychotic disorders that are separate from the eating disorder, and then psychedelic substance abuse in the history. One of the things about ketamine that's very important to consider for this population uniquely is that ketamine can cause nausea. And so when patients with eating disorders have experiences of nausea, those are things we want to manage really carefully, and it can be challenging for patients who have emetophobia or fear of vomiting, as well as patients who have history of purging disorder. And so we want to manage that both with medications like Zofran, but also by supporting them to get their meals and snacks in such a way that they are not necessarily getting a large dose of ketamine right after lunch or something like that, so that they have the ability to sort of change and modulate their overall nutrition for the day to support the psychotherapy. Let's see. And then for the therapeutic considerations, so ketamine is a unique agent in that, like I've talked about the neurobiology of it, it's very powerful as a neurobiologic treatment for the treatment of depression. And there is evidence that it potentially works even better when combined with ketamine-assisted psychotherapy. Because ketamine induces a non-ordinary state, it is something that is important to be preparing for the psychotherapeutic treatment with a quiet space, planful, intentional creation of sort of what is your goal for this treatment, and then how can you use the uniquely malleable state after treatment or during treatment to address some of the things that might be blocking your ability to move forward in treatment. At ERC, we do symptom scales day of and day after to gather information. And I think that this is important because as the world evolves and we have access to more and more things, it will be important that we figure out how to collect data and see if people are having an actual good response to things. So we do symptom scales as well as objective data, especially related to their eating disorder symptoms. And we have analyzed some data. This is in press and not published yet, but we are analyzing about 100 of our patients who received ketamine treatment in the course of higher levels of care treatment for their eating disorders, and had a wide variety of eating disorder diagnoses, as well as in addition to their treatment-resistant depression, which they have to have in order to get ketamine at ERC, they also had other diagnoses like generalized anxiety disorder, or trauma, or OCD. And what we have seen is that through the course of their treatment, which was highly variable depending on how many doses they got, we had a significant decrease in their depression scores as well as their anxiety scores. I think the very important thing that we saw with this data is that we had a divided population, some of who were actually under target weight by more than 85% of target weight. This says IBW, but it actually was calculated based on their dietitian calculated target weight. So not IBW based on just sort of objective scales, but personal weight goals. And we know that what exists right now for antidepressants that are, people have to take daily and work over the course of 6 to 12 weeks, is that they don't work very well when people are underweight. And what we saw is that in the ketamine, there was not a difference if they were underweight. So we have promise and hope that potentially ketamine could be a treatment for patients who are significantly underweight when they're not responding to other medications to treat their depression or treatment of suicidality. And they did gain a significant amount of weight to say they were in treatment for their eating disorder. So we hope that they would be weight restored in the course of treatment. But as you know, that does not always happen in treatment. So this group of patients, 96 of them, were able to demonstrate a significant improvement in their weight from the beginning to the end of their ketamine. The end of their treatment. So we know that ketamine likely does treat co-occurring depression that occurs in the context of their eating disorder, and they actually maintain their eating disorder, and addresses acute suicidality that may interrupt their ability to remain in treatment. We suspect that ketamine will also increases their cognitive flexibility, stimulates their neurogenesis or brain rescue, so grows new neurons in the course of treatment that may have been lost to malnutrition, allows distance from identity fusion with the eating disorder, allows for new habit formations, and helps to reset reward centers and challenge fears. So I want to sort of say that what we have right now in the field is ketamine, which is available and has to be prescribed and should be done in a medically monitored situation. And then other neuromodulatory interventions like TMS and ECT, and some bigger ones like DBS. And then we've got a whole bunch of stuff on the horizon that we just don't know very much about yet. And very, very importantly, there is no data on adolescent use of psychedelics for eating disorders. We are seeing that ketamine can be helpful for older adolescents, and we do use ketamine for older adolescents in our eating disorder population. But for all of the other stuff that's on the horizon, I wanted to give you a bit of an overview of what they are and what the field is showing, and say that we are cautiously optimistic and watching very closely to see what the actual research shows about the use of these substances in the treatment of eating disorders, and especially severe or treatment-resistant cases. I'm going to stop there so we have time for questions.
Thank you. I'm so impressed that you did that so quickly. It was a lot of information to go through. We didn't have a lot of time, so yay you. Okay, so I'm going to start with the first question, which was, does ketamine increase flexibility with those with autism?
Oh, that's a great question. So let me just say that at the moment, it doesn't appear that anybody's actually gathering cognitive flexibility scales when they're using ketamine for treatment. So I don't have the research answer for that. Anecdotally, I have seen ketamine increase cognitive flexibility in most people, I'm trying to think of a case if I've ever seen someone who had less cognitive flexibility after the use of ketamine. It does increase cognitive flexibility, just in the way that it loosens some of, the way that mental illness, depression or anxiety or suicidality can kind of like lock your brain into a bit of a vise. So it does seem to increase the ability to access cognitive flexibility. And every individual has their own sort of temperamental baseline of how much cognitive flexibility they're going to be able to access. So I don't think ketamine makes people have access to a temperamental sort of orientation that they wouldn't have at their sort of neurocognitive best. So it more just loosens the way that mental illness can make our brains get into those sort of deep trenches that are hard to get out of.
And what's the minimum age at which you administer ketamine?
So we administer ketamine down to the age of 14 at Eating and Recovery Center. I know that in the research, there is evidence for the use of ketamine in younger ages. I can't speak to exactly what's happening in the field of the ketamine clinics that are available in a lot of communities. I would only say that if you have a younger child that you are curious about this intervention, I just strongly encourage you to work with a child and adolescent psychiatrist. And make sure that you have a child and adolescent psychiatrist involved in helping you navigate the pros and cons of that intervention.
Can ketamine be administered in an outpatient setting?
So it can, yeah. So it can be administered in an outpatient setting. What I would say is that the FDA has indicated that it should be administered with medical oversight. So sometimes that can look like an outpatient clinic where you go in, you do a ketamine clinic, there's a nurse or a medical assistant who's there, maybe in the room with you or just outside the room. There's a physician available or a provider who is on site to be able to prescribe the medication. And then at the end of the treatment, you may go home and be home that evening. It is not recommended you drive after ketamine. So it is recommended that if you get a treatment, you have someone to support you with getting back and forth. In an abundance of caution, I would recommend having someone be with you because ketamine, after a dose of ketamine, there can be some emergence experiences that can sometimes be a little bit disorienting. So what we notice is that sometimes people get a little bit agitated as they're emerging from the ketamine treatment, or can get disinhibited is actually the most common thing that happens. So I think that it's helpful to just have some support, whoever that is, and not be alone after the treatment of ketamine. But it can be done in an outpatient setting where you are home that morning and you're home that evening, just that someone is supporting you in the course of getting the treatment.
What is known about the use of psychedelics for the treatment of ARFID?
That's a great question. And the reality of the answer is almost nothing at all. It is so unfortunate that, ARFID still does not have as many overall just research happening with ARFID right now. So I did not see any trials that are specifically recruiting for patients with ARFID for the use of psychedelics and the treatment of ARFID. There are trials looking at the use of psychedelics in the treatment of various anxiety disorders. And so if ARFID were to occur concurrent with another anxiety disorder, potentially people are gathering some of that data. But unfortunately, there is really very, very little known about psychedelics and ARFID.
Okay. One question. As a medical professional, I'd like more understanding of the neurobiological pathways. Do you have recommendations that may be helpful?
Yeah, absolutely. So I know that we have some CME in our portal, and then there are a number of other organizations that have put out reputable CME on the neurobiology of psychedelics. I don't know if I can pull any off the top of my head at the moment, but for instance, I trained with the MAPS organization and MDMA assisted psychotherapy, and I know that MAPS has in the past had some reputable continuing education around psychedelics and the neurobiology of it. The American Society for Ketamine Providers, also ASKP3, also has several CME options, especially related to the use of ketamine. So I would recommend that you look for a reputable society, a medical society, or something like that might have some additional learning on this field.
I have a question. We had looked into ketamine when my daughter was sick. And part of, I think, what scared me was not knowing how many treatments she would need. So do you have any insight into, I mean, do you have a better idea now, these many years later, of an average of treatments, or what's considered to be the boundary of safe?
Yeah. That's such a good question. And I wish we did, but we don't. And I think that part of why we don't know how much ketamine any individual is going to need is because it's somewhat dependent on how sick they are or have been over time. So how persistently underweight have they been? How persistent has their depression been? And so, ketamine, like I sort of said, it works quickly. So most people have a response to the dose, but then it doesn't necessarily last. And so how many repeated doses do they need is something that we just don't have good insight into right now. And that's why I, recommend sort of doing a course and then taking a break and seeing where things are. Ketamine is very interesting in that it can be used as a single agent, but it can also, I think, functions really well as sort of an adjunct or jump start to treatment. So patients who are struggling significantly with depression or suicidality, and they've got that other SSRI on board, but they're underweight and it's going to take 12 weeks for that medication to work. So we can use this to ramp up quickly and then help them maintain on a more traditional antidepressant agent that might help them maintain at a lower level of care and stay out of higher levels of care treatment or need less support around psychological safety. There are patients who get ketamine in sort of discrete interventions. So they get ketamine for 3 or 4 weeks, and then they take a break for 6 months, and then they might need some boosters. And so there's a lot that we're still discovering about what's the optimal way, what's the safest way, what's the most indicated way, what's gonna actually help people recover. Because I know that well, first off, most of us are of the mind like we want our loved ones to have relief from their suffering. We want them to have access to things that are going to help them navigate the course of treatment and feel better and have a life worth living. But then also, we don't really want to compel them to have to be on an infusion medication that they have to go get twice a week for the rest of their life. So we want something that helps them get better and then not have to be on a medication that, especially one that requires that much oversight and intervention for years. And so my hope is that we will have more of those answers in the coming years.
Okay, final question. We don't
Yes.
have that much time,
Yeah.
so try to answer fast. I've heard there are issues with ketamine for someone with bipolar disorder. Is that diagnosis a valid reason not to pursue this type of treatment?
That's a great question. So ketamine is actually indicated for bipolar depression and has good evidence for bipolar depression. It can precipitate mania. So we do not give ketamine if someone is in a hyper sort of in a manic state or going into a manic state. And obviously it's in spring, which is a high risk time for people to become somewhat manic. We watch really, really closely. Bipolar disorder requires, again, good psychiatric oversight and management, but bipolar depression can respond really, really well to the use of ketamine, especially since bipolar depression has such a high risk for suicidality. So it is an indication. We do use that at ERC, and it is something that can be done safely with the right amount of oversight.
Thank you so much. Thank you, Dr. Wassenaar. This was really, really fascinating and so informative for all of us who are here. We're going to just say goodbye. I would like to just point out that all of our services at F.E.A.S.T are free of charge or highly subsidized. And if you can help us at F.E.A.S.T so that we can continue to offer these programs to the greater F.E.A.S.T community, please go to our website and you can just donate. Any amount is really helpful. So thank you very much. And I wanted to just promo next month's webinar. It is called Compulsive Exercise and the Safe Return to Movement and Sport. It's going to be on June 5th. I think it's going to be a really interesting webinar as well. So please join us then. Again, thank you everyone for joining us. Thank you, Dr. Wassenaar, and everyone have a really good day or evening wherever you live.
Thank you so much.